Okay, so welcome everybody. This is the first of our endocrine continuing education series, and we're starting with hyperadrenocorticism and hypoadrenocorticism. And what I really wanted to do in this talk is, it is very much weighted to dogs with HyperA and HypoA, just because that's what we see clinically a lot more than in cats, but there are a few token slides on these diseases in cats. But I really aimed this talk at the sort of experienced general practitioner level. The reason being is that you're seeing these diseases, relatively frequently. You know how to diagnose HyperA, you know how to manage HyperA, and the same for HypoA. And so I just really wanted to give you these little extra pearls of wisdom that can take your I guess, identification, diagnosis, and management of these diseases to the next level. So some really good statistics to pull out of your back pocket when you're liaising with owners, some little key bits of information for slightly unusual presentations of these diseases, so that when you do eventually see them, there are these little sort of alarm bells ringing in the back of your mind. So this is very much not a talk of a sort of the holistic start to finish HyperA standard case. It's more about saying, okay, here's something interesting for presentation, here is something interesting for diagnosis, and here is something interesting for treatment and management, to take your cases to the next level. So we're going to start with hyperadrenocorticism, and there was a ACVRM consensus statement on this disease back in 2012, 2013, which a lot has changed since then. So whilst there is still some good information in that paper, and this one is open access on Google, so if you just Google that consensus statement, you can access it. But there is, I guess, some of it that is now out of date. So I think that the ACVM would be looking to update that. The most recent paper that I could find is a review on treatment of canine Cushing syndrome. So it's looking at our current options, but also future treatments that are available. And that was in 2018 in the Veterinary Journal. So if we start with hyperadrenocorticism, I did want to just look at sort of what are the classifications of HyperA. So certainly we do see iatrogenic, which is the most common. And then we do all know about pituitary dependent disease. So that's your functional pituitary adenoma, your invasive adenoma, so an adenoma that actually goes into the surrounding tissue, and then rarely they're carcinomas. Followed by adrenal dependent disease, so they're typically your adenomas and carcinomas. However, don't forget about the less common presentations of HyperA, which are the hypothalamic dependent, which is actually yet to be described in dogs but is seen in humans. So that's where you have hypothalamic disease causing a pituitary hyperplasia. The next one is ectopic dependent disease, and that's where you have a non-pituitary excess ACTH production, so ectopic ACTH production, and that's associated with small cell lung tumours, carcinoids, and a few other diseases, but they're still pretty rare. I think one combination that we should have on our radar are the dogs that have both pituitary dependent hyperadrenocorticism and adrenal dependent hyperadrenocorticism. And that's certainly been described, and in a study of 17 dogs, they had an adrenal tumour, but then also had contralateral adrenal hyperplasia. So I know we all know the very typical presentations associated with HyperA, but other presentations to have on your radar would include signs associated with a pituitary tumour growth, adrenal tumour growth or invasion, metastatic lesions, diabetes mellitus, systemic hypertension, and thromboembolism. And this is a picture of a dog that I saw a few years ago that had some of the classic signs like calcinosis cutis lesions, the pot-bellied appearance, the very thin abdominal skin and prominent cutaneous vessels, but actually presented to me because of significant trouble walking in the back legs, and he had really severe ligament laxity, and these are actually traumatic ulcers because this dog was walking on his knees most of the time. So if we think about pituitary tumour signs, we really need to think about moderate to severe lethargy, inappetence, or even anorexia, and that would be really important in a dog that's previously been polyphagic, which you would expect with HyperA, stupor or circling, aimless wandering. And I have a video, but I haven't actually tested it to see. Anna, can you comment if this will go to the internet? We might just try it and see what happens. So this is just the aimless wandering seen in a dog with a pituitary tumour.
I don't think it's playing, Liz.
Oh, isn't it? Oh, I can see it beautifully. Okay.
Yeah.
You might have to share that screen. So undo this share and then share your video.
I'm sure you can all imagine a dog aimlessly walking around the room. And then lastly, ataxia and behavioural changes and seizures. Okay, can you see that screen now? Is that still showing? Yeah, okay, so again, you all know the standard clinico-pathologic findings, but ones to have on your radar is a decreased urea. So 30 to 50% of dogs with HyperA will have a low urea due to diuresis. And that's really important because azotemia is uncommon. So if you see a HyperA dog present with an azotemia, that needs to ring alarm bells. And some clinicians actually consider the presence of azotemia, so for example, dogs with chronic kidney disease, to be a contraindication to treat hyperadrenocorticism. I think in those cases, you really need to weigh up the pros and cons of treating each disease and which is sort of the dog's biggest issue. You can anticipate that there will be an increase in bile acids in about 30% of dogs that sort of have unknown clinical significance, but also that dogs with HyperA can often have an increase in your CPLI test. And that can be present in dogs with HyperA without a clinical pancreatitis. And that's really important when you have a dog with Cushing's that suddenly is unwell. If you do a CPLI and it's abnormal, you really just need to do a follow-up test. That might be something like abdominal imaging to really assess the significance of that CPLI. Other pathologic findings will be for proteinuria. So normally in dogs with HyperA that have an increased urine protein creatinine ratio, it's not usually greater than 1 to 6, but proteinuria can persist in a significant number of dogs even once they're controlled for their Cushing's. So if you're doing your routine follow-ups, you certainly don't need to be doing it every time you see them for an ACTH stim test, but you should still be intermittently monitoring any proteinuria because it may persist despite treatment. And then if you're chasing a diagnosis of hypothyroidism in a dog with HyperA, you do need to interpret these findings with care. So your total T4 and free T4 are often low, and the flip side of that is that in some dogs, their free T4 can be increased, but when their total T4 is low, they will often have a normal to decreased TSH level. So when you're doing your hypothalamic pituitary thyroid axis testing, it is suppressed by cortisol excess. So your TSH concentrations will increase after treatment for HyperA. So just keep that in mind that you might need to chase that diagnosis if it's not urgent once the HyperA is better controlled. So with adrenal gland size, we'll start with interpreting that in pituitary dependent HyperA. So the traditional measurement used to be that adrenal gland sizes shouldn't be bigger than 7.4 millimeters, but we now know that adrenal gland size does vary with breed and body size. So for example, in Yorkies, the caudal pole measurement of their left adrenal is 5.4 millimeters and the right is 6.7, and can then compare that to Labradors who have a caudal measurement of 7.9 millimeters and 9.5 millimeters. So you can see there that breed and body size absolutely does play a role. The other thing with interpreting adrenal gland size on ultrasound is that older dogs generally have larger adrenals than younger dogs. But when you are chasing a diagnosis of HyperA, 25% of HyperA dogs will actually have normal sized adrenal glands. So the absence of bilateral adrenomegaly does not exclude a diagnosis of hyperadrenocorticism. Also keep in mind that enlargement can be asymmetrical due to nodular hyperplasia, and that there is going to be some overlap in adrenal gland size between normal dogs, ill dogs, and HyperA dogs. If we then look at how adrenal gland tumours or adrenal gland size fits with adrenal dependent HyperA, the echogenicity can be really variable in a functional adrenal tumour, so it can be sort of quite solid. So this is actually an image from during the week of a dog that had a tumour that was 1.8 by 3.4 centimetres, but they can be quite cystic, and we also really want to assess for vascular invasion. This I thought was a really interesting point in one of the papers I referenced at the top of this talk by Sanders that was published in 2018, where they recommend that we actually do a lot more advanced imaging as our diagnostic imaging modality of choice. So they recommend that a CT or MRI scan is preferred because it allows us to determine the size and the contour of the pituitary and adrenal glands. So you can do a head CT, an abdominal CT, and in the case of adrenal tumours, it allows you to better assess the vascular invasion and to screen for metastasis. So their argument is, given pituitary tumours and adrenal tumours can coexist, that incomplete imaging may result in missing such coexisting lesions. So that may be something that we transition to. I'm not going to talk through low-dose DEX tests because I think everyone knows how to do it, but you just need to consider that reliable results may not be seen in dogs under stress or those being treated with phenobarbital. And there is this protocol for those dogs that are really hard to get, venipunctures. It's a urine cortisol creatinine ratio to low-dose dexamethasone suppression test, and it's a combination. So with this protocol, owners can collect urine sample on 2 consecutive mornings for baseline UCCR at 8 a.m. And then after collecting their second sample, they give an oral dexamethasone dose. Later in the afternoon, the dog's bladder is emptied, and then they collect another urine sample at 4 p.m. And you can use those results to look for cortisol suppression. So in a normal dog, you'll get greater than 50% suppression in your mean UCCR and a decrease in the ratio to less than 10. And in HyperA dogs, you don't get this level of suppression. So that can be good for dogs that just don't really cooperate particularly well, or for owners who are particularly concerned about having their dogs in hospital all day. I don't tend to do high-dose dexamethasone suppression tests very often, and I think sometimes it's just confusing when they're indicated. So we know seeing a decrease in cortisol suppression on your suppression test is consistent with a pituitary-dependent HyperA. So, but what we know is that in your low-dose dexamethasone suppression test, you can get dexamethasone resistance where you don't see that suppression going down, is seen in about 35% of dogs with pituitary-dependent disease, and also almost all dogs with adrenal dependent disease. So that when that occurs, it makes it difficult as a discrimination test. High doses of dexamethasone, however, can overcome this resistance in dogs with pituitary dependent HyperA, and that's where the high dose dex test comes into it. Having said that, a high-dose dexamethasone suppression test provides additional information in only 10% of dogs who fail to suppress on a low-dose low-dose dexamethasone suppression test. So I don't think it's particularly useful because it's really going to only help you in another 10% of dogs. Probably if that's sort of the line that you're chasing diagnostically, it might be more beneficial to perform an endogenous ACTH level, which I actually think is a test that I underutilize. So when to perform an endogenous ACTH level, it's really important to know that this is not a screening test for hyperadrenocorticism. It's a differentiating test between pituitary-dependent disease and those with adrenal-dependent disease, or potentially iatrogenic HyperA, but from the medical history, you should know that. So what you see in pituitary-dependent HyperA is that you should have a normal or high endogenous ACTH level. So your pituitary is going nuts, you've got a high ACTH level, and that's why you've got your adrenals overacting and producing too much cortisol. That compares to adrenal-dependent HyperA, where you have this autonomously secreting adrenal gland pumping out all of this cortisol. You get the negative feedback and your endogenous ACTH levels go down. So in adrenal-dependent disease, it's going to be low or undetectable. One of the best situations to use this test is in cases of pituitary-dependent disease that have an asymmetrical nodular hyperplasia, where you're just not sure if it is an adrenal mass or not. If you are going to perform this test, you just need to keep in mind sample preparation, as there are some specifics for this. The other thing I wanted to touch on is atypical, or what's also known as occult hyperadrenocorticism. So with this disease, it's where you have dogs that have the clinical signs and the physical exam findings and the CBC and biochemistry findings consistent with HyperA, but your specific diagnostic tests, so your low-dose DEX test, your urine cortisol creatinine ratio, and your ACTH stimulation tests are all within the reference ranges. So these dogs that just look like they have HyperA, but you just can't prove it. In those cases, there are three possible theories. Either that these dogs have an abnormally increased cortisol precursor concentration, but then their actual cortisol levels are normal, or these dogs have mild or very early hyperadrenocorticism and therefore have normal results just because of the cutoff values that we use. Or the third theory is that there is individual variability in cortisol sensitivity that results in some dogs with a high sensitivity showing clinical signs of HyperA at a lower cortisol concentration. So for example, if Anna is a normal dog, she wouldn't show signs of HyperA at a particular cortisol level, but because I'm particularly sensitive to cortisol, I might have what is traditionally a normal cortisol level, but have signs of HyperA. Sometimes measurement of a 17-hydroxyprogesterone before and after your ACTH stimulation test can help diagnose these, but not always, but that's a potential test that you can do. So the next, I guess, decision with these cases is whether to treat, and certainly not all dogs with HyperA, especially pituitary-dependent disease, need immediate treatment. Treatment for this disease is not benign. There are certainly some consequences that need to be considered, but having said that, we know that untreated dogs have a shorter median survival time. So it's about 359 to 500 days that's reported, and certainly this is shorter than dogs that are treated with trilostane. One treatment that's worth considering now that we have the ability to do hypophysectomies in Sydney, because it is the treatment of choice in humans with pituitary-dependent HyperA, is considering this in particular cases. And there was one case series that came out a few years ago of a study of 306 dogs that had pituitary-dependent HyperA that went on to have hypophysectomies, and 91% of those dogs were alive after 4 weeks, with remission confirmed in 92%. Disease recurrence was there, so that occurred in 27% of dogs, but their median survival time was pretty good at 780 days and had a prolonged median disease-free interval. It's not a condition to treatment modality for owners that can't give medications, because they do still need lifelong medications. It can be cost prohibitive. It is very expensive, but it is something that is potentially worth considering in particular cases. I wanted to spend a lot of time talking about trilostane because I think that's probably the drug that most of us use for our HyperA cases. And the pertinent things with trilostane is that as body weight increases, your actual required trilostane dose will decrease. So keep that in mind in the bigger dogs. And absorption is absolutely improved if given with food. So it's really important you instruct owners to give with food, and particularly when they come in for their stim test, that they don't think, oh, they're having a blood test, they better be fasted. That could actually affect your results. So make sure that they're consistently giving it with food.
Can I ask, Liz?
Yeah.
Just quickly, with the use of compounded trilostane, compared to Veteral, whether you see any particular change or difference in how quickly it gets under control, or how well the dogs respond to that? Do you have a sense of whether compounded medication is really that different to your branded kind of medication?
I don't think I see it in terms of the time it takes them to get to be controlled. I think probably the most common times I will see it in a dog who has been well controlled and then suddenly isn't, and it coincides with a new batch of compounded drugs. Certainly there is literature that says that there have been some compounded formulations where the amount of trilostane indicated on the prescription is not what is in the compounded formulation. So I do think that that needs to be considered. The tricky thing with vet oral is just the formulations that are available. And I do think that sometimes you are sort of forced to go to compounded initially. So I think my general rule is if you can avoid compounded drugs, then you should, but there are certainly situations where the current vet oral formulations just are not correct for that size dog. So you sort of, it forces your hand. Yeah.
Okay.
Are you seeing that on compounded drugs it takes longer to get to control?
No, I mean, I think sometimes with some clients, when we talk about the risks of overdosing and causing hypoadrenocorticism, certainly we've had like quite a few clients who want to take it really slowly and maybe start with like a half dose and then do an ACTH to prove that they're not overdosing, and then get to the 30 milligram BID kind of dosing. So I think that tends to be more of a compliance or like a caution sort of thing for us, you know, getting it under control. But then once we seem to get the right dose, certainly from a compounding point of view, I might have had maybe 1 or 2 patients where you just feel like they're not getting the right sort of results for the dose that they're on. But generally I've felt like compounding's been good or adequate. I don't know.
Okay. Yeah, no, that sounds fair. Yeah, so the other thing to consider with both mitotane and trilostane is absolutely they're going to decrease your cortisol secretion. That's the whole point of giving them, but they are going to increase your ACTH secretion, and that can actually enhance pituitary tumor growth. So especially in younger dogs, it is some of the literature leaning towards doing CTs or MRIs after 1 year of treatment, and then monitoring their pituitary size, so that if it is getting really big and we're worried about consequences of the pituitary mass size, that we can then act on it, which I think is something that we don't do routinely, but in the more recent literature is sort of being pushed a little bit harder. So certainly when I started in general practice, there was this traditional dosing schedule of just, you know, here's a body weight, here's your rough milligram dose, and it was sort of these blanket and quite broad ranges. And I think now we sort of have transitioned to more of a milligram per kilogram dosing schedule, and this study from 2013 supports that. And what they found in comparing the traditional dosing schedule to a milligram per kilogram schedule, albeit only once a day, is there was absolutely clinical improvement. There was absolutely a decrease in your cortisol concentration, but there was a lower risk of side effects in those dogs that were on the milligram per kilogram dosing group. So I think that there is an indication for us to try and give more tailored trilostane doses based on a kilo body weight, rather than using these broader body weight guidelines. The other debate is about trilostane once a day or twice a day. And the reason for that is that there is really significant variability in the duration of cortisol suppression. So in most dogs, you have a cortisol concentration is suppressed for less than 12 hours. And so that's really important to keep in mind in dogs who are poorly controlled on a once a day dosing. And what we also find is that on dogs on twice a day treatment, that their total daily dose needed to get good control is generally lower. Having said that, it is rare, but in some dogs who aren't really responding as much to once a day or twice a day treatment schedules, they actually may do better on 3 times a day, but that certainly is very uncommon. So I will actually normally try and start dogs on twice a day trilostane if owners can comply with that dosing schedule and if they can afford that dosing schedule, and normally at about 0.5 to 1 milligram per kilogram. If they can't do twice a day, then we'll do once a day, and I normally start at 1 to 2 milligrams per kilogram. If we look at the studies that look at once a day versus twice a day dosing, these are 2 studies that compared mitotane with once a day trilostane or mitotane with twice a day trilostane, and we compare those survivals. The survival is better with trilostane twice a day. Those on twice a day, the median survival time is 900 days, and in once a day treatment, it's 662. So the survival is quite a bit better if you go to twice a day dosing. In terms of setting realistic client expectations for trilostane, so they should see an improvement in PUPD within 7 to 10 days, an improvement in polyphagia within several weeks, but improvement in skin changes can take several months. And it's really important to warn them that actually the coat changes can get worse before they get better because of having to shed all the dead hair and skin, so the owners will see a worsening of scale and alopecia. The other thing to watch for is that those dogs who have hypertension at at the time of their diagnosis. That's about half of HyperA patients, but that doesn't necessarily resolve in dogs on trilostane. So again, you should be getting them in for rechecks and doing their blood pressure measurement and watching that. Another thing to warn owners about is just the risk factors involved with treatment with trilostane. So the studies show that 15% of dogs on trilostane will have at least one episode of clinical hypocortisolemia in the first 2 years of treatment. So it's really important to counsel owners on what some of those signs will be and almost prepare them that there is a chance that it will happen. So then if it does eventuate, they're certainly not shocked by it. I now wanted to just troubleshoot some of the ACTH stim test results that you can get. Certainly, I imagine most of you are using the ACTH stimulation test for your monitoring. So the peak effect that we see is about 2 to 3 hours. The peak effect of trilostane is about 2 to 3 hours post-pill. So that's when you really should be doing your ACTH stim tests. Having said that, if you're doing trough studies, so you want to look at duration of action, you're giving that just before the next dose. So in dogs that are on twice a day dosing, you're going to be doing your stim test at 8 to 12 hours post-pill. And in dogs on once a day dosing, you want to be doing that 24 hours post-pill. There was also a study that looked at trying to conserve synacthin to see if they could make it more economical. And in this 2016 study, it concluded that for diagnosis, you still need to use the 5 microgram per kilo synacthin dose IV. But with monitoring, you can actually still get reliable results with 1 microgram per kilo synacthin. So that's really helpful in owners who find it cost prohibitive, but also in periods where synacthin is difficult to access and you're trying to sort of conserve the amount that you have left in the clinic. So some ACTH stim troubleshooting. So the most important thing with this is to look at what the dog is doing. So if you have clinical signs of a poor appetite, diarrhea, vomiting, or lethargy, if your post-stim cortisol is greater than 55, then you can discontinue trilostane for 5 to 7 days, but hypoadrenocorticism is unlikely and you need to go looking for other diseases. But this is what to do if you have a post-stim cortisol then it's less than 40. In this protocol, you discontinue your trilostane for 2 to 4 weeks. If there's azotemia or hypokalemia present, then you need to really treat them as an Addisonian crisis. Then retest them in a month and every 3 to 6 months to then determine when your Addison's treatment can stop. When you retest, the different results I've listed here. So a post-stim cortisol of less than 40 means that adrenal necrosis is likely. If you have a post-stim cortisol of 40 to 275, so more in that sort of normal range, then there's no current indication for trilostane and you can just retest them in a month and then every 3 months to see if that changes. But if your post-stim cortisol is greater than 275, particularly if you have clinical signs of HyperA, so your PUPD, your polyphagia, then restart your trilostane, but with a 25 to 50% dose reduction. It's different though if a dog presents to you with a normal appetite and normal stools and normal energy. So if the post-stim cortisol is still less than 40, you can just discontinue your trilostane for 5 to 7 days and then restart your trilostane with a dose reduction of 25 to 50% and then retest them in 2 to 4 weeks. At that retest, if their stim cortisol is still less than 40, then discontinue the trilostane and retest them. If you're getting better numbers with a post-stim cortisol of 40 to 150, then you've probably got a pretty good dose at that point and your dose can be unchanged. If, however, your cortisol is greater than 150, you can either leave the dose unchanged if they're otherwise clinically doing well, or if you want tighter control, then increase that dose. So make sure you evaluate 10 to 15 days after any dose changes, then at 1 month, 3 months, and then every 6 months. But it's really important you maintain the exact same timing of your ACTH stimulation tests, so you're comparing apples with apples. really important to have realistic goals for your first ACTH stim test. The goal is just to avoid overdose. You don't actually need to change your trilostane at your first stim test. It's just making sure that you're not pushing them too far. Give them a bit more time on trilostane, even if they're still showing clinical signs or their cortisol is still really high. You don't need to change your trilostane dose unless there is some significant comorbidity that means you need to get rapid control. But otherwise, try and avoid a trilostane change at that first ACTH stim test. So when you have cases like what Tash indicated where they're just not sort of responding to treatment correctly, your list of treatment failures that you need to consider are either inadequate dose of trilostane, an inadequate frequency of trilostane, poor owner compliance, or it is a quality control issue with the formulation. So as we said, there can be some concerns with some compounded medications. Certainly another one to consider is radiation for pituitary-dependent HyperA. It is more effective in dogs with small tumours though, so early treatment improves prognosis and survival. So this might be another indication for why we should actually be doing CTs as part of their diagnostic workup. Pituitary-dependent disease is often pretty sensitive to radiation, but again, having realistic expectations, radiation is pretty good at shrinking the tumour, but it's not so good at resolving the clinical HyperA signs. They often still need some kind of medical treatment. To then move to adrenal dependent disease, surgery is the treatment of choice. It can be curative, it's permanent, often requires no long-term treatment if it's unilateral, and actually some dogs can have minimally invasive laparoscopic surgery. So Alan in our surgery service does do laparoscopy, so that can be a much more appealing option for owners than more traditional surgery. I think we used to shy away from doing adrenalectomies because the mortality rate was really high in the earlier studies, but that's now getting better and better. And it's now reported to be as low as 6 to 8%, which is actually pretty good. And their median survival times are good, so 2 to 4 years. Having said that, recurrence of hypercortisolemia varies. So it's reported to be between 12 to 30%. And that's likely due to tumour regrowth or metastasis. I think one thing that often would scare me, and I think the surgeons tell me to be less scared, I don't know if this is your experience too, Anna, but vascular invasion, I used to just be like, no, surgery's too much, I can't do it if there's vascular invasion. But there are some studies that show that vascular invasion does not actually exclude surgery, and some studies have concluded that it doesn't impact on their perioperative mortality. So I think I should actually be considering adrenalectomy in those cases more than I currently am doing. The important thing is that in those patients with vascular invasion is if you can get them through the perioperative period, their long-term survival is exactly the same as those without vascular invasion. So they actually can do pretty well long-term. Here's the token slide on cats with HyperA. It is very rare. I just couldn't bring myself to give a talk without mentioning cats briefly, but it is less common, it's generally more serious, and they have a worse prognosis, just to very briefly sum it up. Unlike dogs, they are strongly associated with diabetes or skin fragility syndrome, but the pathophysiology is very similar to dogs otherwise. The general rule with cats is that they have much more dramatic physical changes and less dramatic clinicopathologic changes. So these are pictures from a JFMS article by Lara Boland and Vanessa Bars at the uni on feline HyperA, and this is just quite spectacular skin fragility syndrome. They get nail bed infections, and this is actually the trauma just from a cat grooming itself, just because its skin was so fragile. And these cats you need to be really careful with, because you can't just clip them for an abdominal ultrasound if they've got the skin fragility syndrome, because it's just going to fall off them. So you do just need to be really careful with handling these cats that you think might have HyperA. So now on to hypoadrenocorticism, unless anyone has any HyperA questions, or we can do them at the end.
That's all good.
No.
Can I just throw in there?
Yeah.
For cats, I learnt this recently when I went to do an ACTH stim test to diagnose HyperA in a cat, but cats tend to be diagnosed much better with low-dose suppression test. If you are suspicious, that's the test of choice for a cat. And the other thing on the CBC findings in HyperA dogs, they've often got a thrombocytosis. And it's something that just, you know, if I've got elevated liver enzymes and a thrombocytosis and some subtle clinical signs, then I'll probably chase HyperA before chasing a liver problem. So it can sometimes just be that extra hint on the blood test that help.
Yeah, definitely. And in cats that have their ACTH stim test, it's actually a different protocol than in dogs. So often it's done at 30 minutes, 60 minutes and 90 minutes, or a slight variation on that too. Okay, so hypoadrenocorticism, which I love as a disease. They call it the great pretender, and I think that it's very true. And I think that there might be more Addisonian dogs out there than what we sort of pick up, and I think that's going to change as we do better screening tests. So certainly primary hypoadrenocorticism is the most common. So where you get adrenal cortex atrophy, it's very rarely due to any infiltrative disease, so neoplasia or infection or infarcts. There's classic versus atypical. So atypical Addison's is where you have absent cortisol secretion, but your sodium and potassium levels are normal. So it's really important you don't just look at your sodium and potassium levels and go, oh, they're okay, they're not Addisonian, because that's certainly not necessarily the case. The other one is secondary HypoA, which again is quite uncommon, but that's either failure of your hypothalamus or pituitary to then tell your adrenals what to do. So in those cases, you will be thinking of neoplasia, inflammation, infection, infarction or trauma. Again, with these cases, their electrolytes are often normal because the aldosterone secretion is regulated by RAS. So it's really just a glucocorticoid deficiency. And in these cases, you can do an endogenous ACTH concentration and they'll be low. So I think most of us sort of know with a CBC is to look for a lack of a stress leukogram in an ill dog. I think it's very easy to sometimes look at test results and go, oh, everything's green and in the normal reference range, there's no red outliers, but in an ill dog, that is actually a big problem. So I think to make an effort of going to in a sick dog, normal results is actually not normal. And also in this study, they looked at ill dogs versus dogs with HypoA, and dogs with HyperA had much lower neutrophil counts and higher lymphocyte and eosinophil counts, but their overall white cell count was still in the normal range. So again, you're not looking for the outliers. It might just be, high normal and low normal. But as we all know, hyponatremia and hypokalemia is the sort of big alarm bell for Addison's, and that's present in 80% of dogs. So these are some guidelines for your sodium potassium ratio. So if it's less than 24, then they're quite likely to have HypoA. But if it's greater than 27, then it's quite likely they won't have HypoA. So don't underestimate your sodium potassium ratio. So I know this is probably straightforward for most of you, but I just love the basal cortisol test as a screening test to exclude HypoA. I think, again, it's really underutilized, and in sort of dogs with GI signs, particularly if they're chronic, we should be doing it. So a basal cortisol greater than 55, they're unlikely to have Addison's. So that I think is a test that we can probably do more of, but if their baseline cortisol is low, then you do need to follow it up with a stim test. So it's not a diagnostic test, it's a screening test. So I wanted to just touch on some key parts with treatment. So when you're presented with a case that's in crisis, these dogs are really, 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 really susceptible to fluid overload. So you need to correct their hypovolemia very carefully, but also you need to keep in mind that rapid correction of their hyponatremia can cause neurological disease. So you really need to get that balance right of rapidly correcting their hypovolemia while ensuring that their sodium does not increase rapidly. I think for most of us, hydrocortisone would be our parenteral steroid of choice. It is equipotent with glucocorticoid and mineralocorticoid activity. And I normally have a CRI dose rate of 0.5 mg per kg per hour until they're eating, and that's when they go on to oral meds. It's important to remember that hydrocortisone, sodium succinate, it adheres to plastic or glass at low concentrations. So place it in its own fluid bag, and I normally make it up to a concentration of 1 mg per ml, and then run it through the giving set before you attach it to the patient. It is incompatible with many drugs. So for example, ampicillin, so dilute it just with normal saline and don't put other drugs in there. So Cortate is probably the glucocorticoid of choice, but if you read a lot of conference proceedings and textbooks, they spend most of the time talking about prednisolone. So cortisone acetate is converted to hydrocortisone in the liver. So you're getting your mineral corticoid and glucocorticoid activity. The benefits of Cortate over prednisolone is that it's less likely to cause iatrogenic hyperadrenocorticism because of its shorter half-life and lower overall activity. So I think it is the glucocorticoid of choice, and I normally start at a dose rate of half to a mg per kg once or twice a day. Once they're stable, you can back off that quite significantly, with often half a mg per kg once or twice a day being sufficient. If we then look at mineral corticoid supplementation, we have deoxycorticosteroid pivalate, or DOCP, which is sort of newer than some of the oral mineral corticoid supplementations we have available, but has been around for a while now. So the recommended dose rate for that is 2.2 mg per kg subcut every 25 days. But we're learning that you can actually get away with lower doses and giving it less frequently. So I normally start at this dose and then measure your serum sodium and serum potassium at both 14 days and 25 days later. And the recipe that I follow is that if your sodium potassium ratio is greater than 32 at day 14, then you can decrease your next dose by 10%. And if your sodium potassium ratio is greater than 32 on day 25, then your DOCP dose can be postponed at least 5 days. So this is the tweaking process you're looking at. You're looking at dose and frequency, and then you just sort of wash and repeat that process. So the main goal is that once your sodium looks like it's decreasing and your potassium is increasing, then that's when your DOCP is given. We normally get a realistic goal of 29 to 32 days. It depends on the owner, I guess, whether once you've got things more stabilized that you teach them how to give those injections or they come into the hospital, but they're sort of your general rules to follow. I think Florinef, so fludrocortisone acetate, is the more traditional mineral corticoid supplement, and the dose of 0.01 mg per kg orally 12 hours, but there are some ranges. So with that, you should be assessing sodium potassium concentration every 5 days, and you're aiming for your sodium potassium ratio to be greater than 28. Keep in mind it has both glucocorticoid and mineral corticoid activity, and some dogs will develop glucocorticoid-induced side effects when you give them enough Florinef to get their electrolytes normal. Sometimes you can actually discontinue Florinef and keep Cortate going in some patients. Sometimes that will be sufficient. However, there is some evidence that DOCP may be more effective than fludrocortisone. So if you're traditionally going to Florinef, it might be time to just try DOCP and see what kind of success you have, because it may be more effective. If you are using Florinef, beware of the fludrocortisone creep. And again, I recommend owners be warned of this. The reason being is that the dose of fludrocortisone may need to increase over time because of a reduction in its mineral corticoid efficacy. But that's less of a concern with Cortate when you're using dual therapy than if you're using prednisolone. Recheck these guys every few months, even when stable. So you should, if you can sort of set up reminders to get these cases in, just electrolytes relatively frequently. One of the hard things to troubleshoot with these cases is when they become PUPD, because we can see that with hypoadrenocorticism. We can see that on DOCP, it can cause a PUPD without causing any increase in serum sodium, but also you can see it with the glucocorticoid or fludrocortisone causing PUPD. So that's a particularly challenging clinical sign to troubleshoot. Cases where you should be performing acetate stims that might sort of not be as obvious on presentation is this is the paper of 4 dogs with suspected PLE. They had clinical signs of PLE. They had a severe hypoalbuminemia and a severe hypocholesterolemia, 2 of which had abdominal effusion or peripheral edema, and they actually had Addison's disease. So I think if you're seeing a low albumin, a low cholesterol and GI signs, really have alarm bells ringing for Addison's disease. And then I wanted to just touch on the neurologic signs we see with fixing the hyponatremia too quickly. So you need to be looking for clinical signs of the myelinolysis 3 to 6 days after sodium correction. So you're going to see signs like myoclonus, ataxia, nystagmus or facial paresis, tetraplegia, or altered levels of consciousness. The degree of correction over the first 24 hours is more important than the rate over any given period in that. So you're probably going to avoid any problems if your plasma sodium does not increase by more than 10 to 20 millimoles per litre in the first 24 hours. But this is why it's really important you watch their sodium carefully. Again, the token cat slide. So HyperA in cats, it's rare, a similar presentation to dogs. They can get spontaneous typical and atypical Addisons, and they can certainly get Addisons associated with rapid withdrawal of steroids. It has been reported in association with infiltrative adrenal disease, so in adrenal neoplasia, but it has also been reported, so this pseudo hypoadrenocorticism in 4 cats that had a peritoneal effusion. So yes, the ACTH stim protocol is different in cats, and the prognosis isn't quite as good in cats as it is for dogs. And that's it. Any questions for Addison's disease?
Liz, I've got one case that is being treated on Cortate alone, and it's been very, very stable for almost a year.
That's great.
Is that unusual?
It is unusual, but it can happen. So because you can get both the mineral corticoid and glucocorticoid effects, then there are absolutely some cases where that works well. So certainly still monitor your electrolytes, but that's really good that you can get away with just Cortate.
Yeah, just once a month.
Yeah, perfect. I've got a question here about any practical tips on what sort of fluid weight we should use in HyperA. I think this is a really interesting question because I don't think there's a good consensus. So some people worry about using straight saline, so 0.9%, and how that's going to affect sort of acidosis and whatnot. I think that just correcting their hypovolemia and their hyponatremia correctly is more important. So I think if you're monitoring it, then it doesn't matter so much. I probably still go for 0.9% saline, but I think there's a fair argument for using something like Hartman's. I think correcting the hypovolemia is the most important thing. Hope that answers your question. But there's no good consensus. Different books and different articles will support different fluid types.
I recently lost one patient who was diagnosed HyperA, and it died of a bleed out into its abdomen.
Yeah, right.
From a tumor. I mean, it happened at NVS actually. It was brought to NVS.
That's sad. I mean, certainly we know that cortisol, so it had hypoadrenocorticism?
No, hyper.
Oh, right.
It was a Cushing's dog. And before we even got to treating it, it had a crisis and bled out into the abdomen. So we thought maybe it might have had a tumor in the abdomen, but we hadn't picked it up at the time.
That sounds very unlucky, Jeff.
Yeah, it was a sad one.
Hey, Liz. I think Raina and I might have asked Anna just very quickly when she was coming to help us with 1,000 cases that she comes and helps us with. But I think there was an article in one of the like CT magazines or one of the vet kind of ed magazines about a vet who sort of suggested that early desexing has really sort of increased the like incidence of Cushing's disease, and that I think he ended up sort of suggesting that either using the GnRH agonists could potentially help lower the use of trilostane or sort of minimize the medical kind of stabilization for Cushing's. I just don't know if there's been any more on that sort of theory.
Not to my knowledge. I haven't seen much report about it. I know that there is sort of this theory about it being associated to sexing, but ultimately is it going to change the way we sort of de-sex patients, probably not, but I can't comment on the use of sort of other hormonal treatments. I'm not across that. Sorry, Tash.
Okay. No. I just wondered if that was sort of moving into the space, but if it's not, that's all good.
Certainly, I know I did a massive literature review last year before my fellowship exams, and I didn't come across any big studies about it. So maybe the lack of evidence might be more important. But yeah, I mean, it might be a watch this space. I think it's just getting so common that even more and more treatments and other theories are going to become available. So it might be something that emerges in the coming years.
Yeah.
Liz, I have a question.
Yeah.
So I'm Anne. I'm a final year student.
Hi.
Just in terms of taking you back to kind of a new grad level, just wanted to ask, how do we approach those atypical cases of hyperadrenocorticism where we're getting all the clinical signs of it, but it's not coming up in diagnostic testing? Do you have any kind of like tips for that, I suppose?
They can be a real nightmare. And I guess you can still, I think it's about having a really big conversation with the owners about saying you can't find any other reason for the dog's clinical signs, and do you just bite the bullet and start them on trilostane and see what response they get? But, you know, by all means, you don't have a slam dunk diagnosis at all. So I think it'd be about prepping them and saying, you know, if he doesn't have HyperA, starting them on trilostane could be problematic, and these are the signs to watch for if we make them Addisonian. And I would just be very conservative, start with very low doses and slowly creep up.
Okay, cool, thank you.
But they may not respond to trilostane, so, you know, yeah, it is tricky.
Yeah, okay.
I'll probably add to that as well, just as something to keep in mind as a new grad, as you're going into managing your own cases and stuff, is a lot of the time you get kind of caught in this kind of steamroll of you've got an elevated ALP and then you go chasing that and you ask the clients and then, oh yeah, maybe there's some PUPD, maybe there's some polyphagia, yeah, maybe they've gained a little weight. And you kind of almost force the syndrome in a patient because of blood tests that you've seen on a pre-GA profile or something like that. And I think the important thing with Cushing's is it's a clinical disease and it's a big financial and emotional investment for the clients to go for treatment. So if the dogs aren't genuinely clinical and the owners haven't presented the dog for Cushing signs or related signs like UTI secondary to that, or panting through the night, or being unsettled, or heat intolerance and stuff like that, I usually just sort of say, watch and wait, you know, let's not do the testing yet, because it's not going to be as sensitive now when it's subtle disease as it's going to be when it's like overt disease, and that's when you want to be treating.
Cool, thank you.
Yeah, absolutely.
Good tip, because that situation arises very frequently.
All the time.
Because out of the blue, sometimes you'll have a very high alkaline force and you sort of wonder, ooh, did I miss something?
Yeah, and I think that, you know, Anna's absolutely right in that you should only really pursue diagnostics for HyperA if you've got a high clinical suspicion of it. And probably the only time that I would still do specific diagnostic testing in that situation is to say to the owner, well, if he has Cushing's, we can then say, okay, we now have a reason for the increase in ALP and we're going to choose to ignore that, and we'll regroup in 3 to 6 months, so that then they at least feel they have a reason. But absolutely, like, you know, the decision once you diagnose HyperA is, are we even going to treat this? Do the benefits outweigh the risk? But yeah, only test for it if you've got a huge clinical suspicion.
That's not bad advice. I got caught in Adelaide with a dog that it didn't really look as though it had HyperA, like clinically, but its biochemistry profile was typical, with an elevated ALT and a much more elevated ALK phos. And I got a false positive on my testing. I started to treat it and sent it into an Addisonian crisis. And it was a false positive test, obviously. And the literature at the time, like the textbooks, saying, well, don't treat them unless they've actually looked like they've got it. But of course, I've had the feeling for some years, though, that the classical signs really are a more advanced stage of the disease, and we weren't picking up a lot of them that haven't quite got that far yet.
Yeah, I think that's a really interesting point, Jeff. Certainly, you know, when you look in the textbooks, you get these very classic pot belly, no fur, you know, like their belly's dragging on the ground type pictures. And I think that most of the time we are picking it up much earlier than that. You know, owners have a different relationship with their pets now than they did a long time ago. They're noticing changes in their drinking, in their appetite, or, you know, just their energy levels on walks. So we probably are picking up HyperA earlier, but, you know, absolutely still need to pick the right time for when we institute treatment.
Yep. Liz, what's the oldest patient you've ever diagnosed Addison's in?
Oldest? I don't think I've seen it above 9. I mean, it's traditionally a disease of younger dogs, but I have had, I think seniors too high, but, you know, older dogs, but I've not ever seen it in double digits, I don't think. Except I think one that was associated with neoplasia.
Yeah.
But I've never seen more typical classic Addison's, yeah.
I think that's an interesting kind of point as far as you kind of index of suspicions. Addison's is an autoimmune disease, and therefore it's more common in young to middle-aged dogs. Most of the time, obviously there's secondary causes and stuff as well. So most of the time we're seeing it in young to middle-aged dogs rather than older dogs. Having said that, though, there's dogs that might be on the cusp of having Addison's and then had a not very stressful life for their whole life and never been tipped into that crisis point. And I got really caught out a couple of months ago by a regular vet who'd had this patient who'd been quiet, had some vague gastrointestinal signs, 12-year-old border collie, and they did an ultrasound on it, had a splenic lesion, they did a splenectomy, which tipped the dog into its Addisonian crisis. The 12-year-old border collie, like with, you know, only a very sort of short-term list of symptoms. And I thought they were wasting their time doing a stim test, but I said, you should tick that box. And it came out positive for Addison. So, you know, undetectable cortisol levels. So I would never write it off. And I think an important thing with Addison's is that often it's another disease that tips them into the crisis. So your blood test might be pointing to the other disease completely. You know, if they've got sepsis, if they've got a urinary tract infection, if they're hospitalised for a GDV, which we've seen recently at NVS as well, just didn't recover very well from its GDV surgery and turned out to be Addisonian. So there's something usually tips them into a crisis. So keep in mind that a sick dog that's not recovering as you might expect it to is another maybe indication to look into Addison's.
I've seen that happen even presumably only with a skin disease.
Yeah, right.
Pyoderma. And it wasn't that serious. It didn't even need antibiotics. I corrected it with Pyodex, but I'm quite sure that's what tipped it over.
I have similarly seen it. It was a standard poodle, which is one of the breeds you worry about with Addison's, but had no strong history for Addison's and was put on ketoconazole for its skin disease, and that pushed it into Addison's too, which was an interesting way. But
and would you expect those that are sort of like subclinical for their baseline cortisol to still reflect that? Or do you think it's only in that symptomatic crisis zone that if you took a baseline cortisol, that would then kind of reflect that was happening?
As in, so when they're no longer under stress, they have adequate cortisol levels for day-to-day life?
Or just like a baseline low, or is there something that means that they're sort of just sitting just within a normal amount of cortisol that they're okay? And so if, say, you had like a chronic enteropathy case and you took a cortisol level just as a sort of screening test, if they weren't sort of clinically in a crisis, would you still expect them, if they were Addisonian, to reflect that in their cortisol, regardless of if they were in their crisis zone or not?
I would, that's a good question. Maybe. I think the answer is maybe. Like, I think if they're teetering on the edge, then probably the ACTH stim would show poor adrenal reserve anyway. But I think if they're on that tipping point, then they're not going to have quite a normal stimulation test result.
Okay.
I think the other thing about these dogs that are developing the crisis when they're already sick is it's not that they're using up all their cortisol, it's that their requirement goes up. So actually the number on a blood test is still going to be the same. It's just that they need double that because they're really, really stressed, so they need more stress hormone.
Yeah, in other words, the Addison's precedes the illness, but they were coping until they needed a bit better response and then couldn't get it. Is that do you think that's the case, Anna, or not?
I do think so. Yeah, I think they've only got so much adrenal capacity. They don't have any reserve to increase their cortisol producing capabilities. So they've only got sort of 40 of cortisol, and all of a sudden they need 80. Like, it was fine for everyday life, but they need 80 today. And that's when they tip into a crisis because they can't then maintain the blood pressure and things like that. That's just the way I've sort of pictured it in my head. It might not be right, but...
Which I think is very important to point out with that scenario in a dog that's kind of brewing Addison's. It's different to the, if you've heard about like adrenal insufficiency and critical illness, which has sort of similar themes, but is a bit different, which we won't go into because it's a bit controversial. But yeah. But I think you still just treat them as Addisonian dogs, and you can probably just get away longer term with lower doses of your medication because they sort of have a smidgen of adrenal reserve there in normal day-to-day life when they're not having their enterotomy, for example.
All right. Thank you so much for doing that, Liz. That was awesome.
Great.
It was.
Yeah, that was great.
Really
Very good coverage. Thank you very much.
Pleasure.
So our next one is going to be with Mariano on Wednesday morning. Everybody's welcome. So if you've got other members of your practices or anything that would like to come, nurses as well, we'll just be going through some more radiographs. But the other thing for Mariano is that if you would like to submit your own cases, he can just talk about your radiographs. It's a really free way to get a free radiograph. And if you have any trouble getting the radiographs to Mariano, very happy for you to email them to me and I can sort out loading them up onto our server. Otherwise, contact me and I can talk you through loading them up yourself. And we'll hopefully see you 9 a.m. on Wednesday morning.
Look forward.
Thanks, everyone.
Thanks, guys.
Thank you.
Good night.
Thank you.